Okay, good evening, everybody. My name is Dr. Gidla. I'm just a new house officer started at San Fernando General Hospital. Today we are going to talk about meningiomas. Meningiomas, this is just an overview with regards to the incidence, clinical presentation, diagnosis, and treatment. Right. What are meningiomas? Well, essentially, they are tumors arising from the meninges, which is the protective brain/spinal membranes. Majority are benign, around 90%. With regards to meningiomas, they can compress the brain tissue without invading. A little bit about the incidence and epidemiology. The most common primary, meningiomas are the most common primary intracranial tumor, representing 54.3% of all primary brain tumors. Here we just have a little chart about the primary brain tumors, seeing that meningioma is the primary one, secondary tumors of the pituitary, and yeah. They are more common in women than men and can occur in all ages, but are typically seen in middle-aged and older adults. So again, we said they are typically benign 90%. And again, they compress but don't invade the surrounding tissue. 10% are histologically malignant and or rapidly growing. So with regards to meningiomas, they did autopsies in patients over 60%, and they noticed that over around 3% of these patients have a meningioma. The median age at diagnosis is 65 years. In children, 1.7% of brain or CNS tumors occur in 0 to 14 years. Meningiomas are 4.6% in the age 15 to 19. And with regards to 19 to 24% of adolescent cases are linked to NF2 or von Recklinghausen's disease. Just a little discussion about the risk factors for meningiomas. They noticed that ionizing radiation is the only established environmental risk factor, especially in children. There is a possible genetic susceptibility to radiation-induced meningiomas. 50 to 6% of WHO grade 1 meningiomas have an NF2 gene mutation in the chromosome 22q12. It's a higher incidence in females and increased risk in postmenopausal women on HRT suggests a hormonal influence. Neurofibromatosis type 1 and type 2 increase the risk as well. Breast cancer. A moderately increased risk of meningioma has been reported in females with breast cancer, and conversely, an increase in the incidence of breast cancer has been observed in females with a history of meningiomas. Obesity is also a risk factor. An association between obesity and meningioma risk has been reported in several large observational studies, with odds ratios ranging from 1.4 to 2.1. This relationship might be related to the endogenous hormonal factors, since obesity is associated with higher levels of estrogen and other growth factors. So this is a little bit about the histological morphology classification. In the fifth edition of the WHO classification of CNS tumors, a total of 15 subtypes of meningiomas are recognized. So this little picture here, we're seeing the grade 1 tumors. They could be pseudomatous, secretory, angiomatous, transitional, fibrous, microcystic, lymphoplasmacyte-rich, and metaplastic. You're seeing here, these are usually the grade 2 tumors. They are atypical clear cell and choroid. And with regards to the grade 3, they are usually anaplastic, papillary, or rhomboid. Just with regards to meningiomas, majority are benign, 90%. So these three types are the most common: fibrous, meningotheal, and transitional. All three are usually primary grade 1 tumors. You can classify your meningiomas based on their location. So majority occur in the parasagittal area, 20.8%. You can find it in the convexity as well, 15.2%. The tuberculum selae, 12.8. Sphenoidal ridge, 11.9. The olfactory groove, 9.8. The falx, 8. Lateral ventricle, 4.2. And the tentorial, 3.6. Little bit about the grading for meningiomas. There's grade 1, grade 2, and grade 3. Grade 1, which is benign, are slow-growing, low recurrence tumors. And again, these are examples of the histological types that we went through just now. Grade 2 are the atypical. They are higher in recurrence and they're faster growing. With regards to the grade 2, you have to see 4 to 19 mitoses per 10 high power fields. There is brain invasion and at least 3 of these, including high cellularity, high nuclear to cytoplasmic ratio, sheeting, prominent nucleoli, spontaneous necrosis. With regards to grade 3, which are anaplastic and malignant, they are aggressive, high recurrence, and poor prognosis. So grade 3 tumors are usually anaplastic. Papillary and rhabdoid were removed in 2021. And in grade 3, you need to see more than 20 mitoses per 10 high power fields compared to the 4 to 19. They are overtly malignant cytology, so they are carcinomatous, sarcomatous, and melanoma matters. So the clinical presentation of meningiomas. Many meningiomas are asymptomatic or minimally symptomatic, and approximately 20% are discovered incidentally on neuroimaging. They present as headaches, seizures, neurological deficits, cognitive changes, weakness or numbness on one side of the body, vision loss, hearing loss, or double vision. But we'll go a little more in depth with regards to the location. So based on the location and the tumor size, they would give clinical presentations. So if it is in the base of skull, you usually get visual loss or oculomotor palsies. If it's in the cerebral convexities, you get focal seizures, cognitive deficits, ultimately signs of increased intracranial pressure. If it's in the clivus or apical petrous bone, you get gait disturbance, limb ataxia, deficits referable to the fifth, seventh, or eighth cranial nerves. If it's in the foramen magnum, you get ipsilateral suboccipital pain, paresis that begins in the ipsilateral arm and progresses to the ipsilateral leg, then to the contralateral leg and arm. There are cranial nerve deficits, and sometimes you get Loomis sign. If it's in the olfactory groove, you get anosmia, sometimes papilledema and visual loss, and Foster-Kennedy syndrome. If it's parasagittal or Falx, you get spastic paresis or sensory loss, usually beginning in the contralateral leg, but occasionally bilateral, and you get cognitive deficits. If it's any posterior fossa, territorial tumors that extend superiorly or inferiorly, you could get hydrocephalus. If it's any sphenoid wing, medial, middle, or lateral, you get oculomotor palsies, facial numbness, visual loss, exophthalmos, seizures, and headaches. And if it's any tuberculum sale, you get visual loss, bone changes sometimes visible with the imaging. So diagnosis of meningiomas now. So diagnosing anything, you need to do a full and thorough history and exam. With regards to the exam, you need to check cognition, hearing, reflexes, and vision. Diagnosing meningiomas, MRI is the gold standard. And in the MRI, you usually see dural-based extra-axial mass. It is iso or hypointense on T1 or iso and hyperintense on T2, and it's enhanced with contrast. In a CT scan, you see a well-defined extra-axial mass, and approximately 20% show calcification. And it displaces the brain tissue. It's smooth or multilobulated. Biopsy is used when imaging is inconclusive or for grading. And with regards to angiogram, it shows the evaluation of the brain vascular, but the use of angiography is now limited to tumor embolization as a component therapy. So this is just an example of some of the molecular markers. Recent studies in meningiomas have provided significant insights into the molecular and clinical characteristics, as well as potential therapeutic strategies. If you look at, they did studies on genetic and epigenetic alterations, and studies have highlighted the importance of genetic and epigenetic changes in the progression and recurrence of meningiomas. Alterations in the chromosomal regions, DNA methylation patterns, and specific gene mutations, example in the third promoter mutation or any of these mutations, are associated with higher grade meningiomas or poorer prognosis. So this is just a radiological case of a grade 1 meningioma. So in picture A, you're seeing a non-contrast axial CT. So you're seeing a large radio-dense extra-axial mass visible. In picture B, you're seeing homogeneous, which is an axial T2 weighted MRI. You're seeing homogeneous signal intensity surrounded by a thin, hyper-intense CSF cleft. So this is the hyper-intense CSF cleft here. In picture D, you're seeing a coronal CT or the bone window. You're seeing a faint hyperdensity along the midline floor of the anterior cranial fossa, suggestive of ostosis right here. And in picture E, you're seeing a post-contrast coronal MRI. Intense homogeneous enhancement of the mass. Area of hypoenhancement corresponds to the area of hyperostosis right here. This is just another radiological study. So this is with regards to parafalcine meningioma, where the yellow arrowheads are. And this is from a 49-year-old woman with a grade 2 or atypical meningioma, presenting with headache and left-sided weakness. So picture A is a coronal non-contrast window CT. The blue arrow denotes edema in the adjacent brain tissue. It's kind of not so visible, but around here. In picture B, you're seeing an axial T1 MRI without contrast. In picture C, you're seeing an axial T1 MRI with contrast. So you're seeing it more visible here. In picture D, you're seeing a coronal T1 MRI with contrast. Note the dural tail, which is characteristic of the meningioma, but not pathognomonic, nor necessary to diagnose. So you're seeing the dural tail here. In E, you're seeing the sagittal T1 MRI with contrast. In F, you're seeing this is a sagittal contrast MRV. Note the lack of opacification of the superior sagittal sinus between the two red arrows, which is located within the borders of the tumor. Just briefly, I'm just going to talk about the Simpson's grading system, which is not used actively in practice anymore. It was introduced in 1957 by Donald Simpson, published in The Recurrence of Intracranial Meningiomas After Surgical Treatment. So his grading system aimed to correlate the extent of tumor resection with the recurrence rate. So based on the assumption that meningiomas are benign and more complete resection equals lower recurrence. But it's not true. Primarily applicable to only WHO grade 1 meningiomas, which are benign. There are limitations as it's less relevant for higher grade tumors, and there's an ongoing debate over its accuracy and relevance today. So there are different grades up to 5 and the description of what you should do, how you should resect it. Treatment of meningiomas. So the primary treatment options include removal with surgery, example, craniotomy or laminectomy, radiosurgery, example, gamma knife surgery, and laser interstitial thermal therapy. The management of meningiomas requires balancing the definitive treatment of the tumor with avoidance of neurological damage from the treatment. When you're treating meningiomas, you must take into account the patient-specific factors, that is, the presence of symptoms, their age and their comorbidities, the location of the tumor, and the grade of the meningioma. So we're treating it based on the WHO classification. So for grade 1, in small meningiomas, so small asymptomatic tumors, you manage them with observation and serial MRIs. The treatment is only initiated if the tumor grows or becomes symptomatic. The surveillance schedule for these small asymptomatic tumors include reassess with MRI in 3 to 6 months after the baseline. If stable and asymptomatic, continue annual neuroimaging for 3 to 5 years, as long as patient remains a candidate for treatment. This is the treatment for grade 1 meningiomas, but large and symptomatic or symptomatic. Surgical resection for these type of tumors is recommended if feasible. It provides a tissue diagnosis, it relieves mass effect, and aims for local control. The goal is complete resection, including tumor and dural attachment, and it can be curative if in an accessible location. For post-surgical management in complete resection cases, there's no further therapy needed. You just do serial neural imaging is advised, and the recurrence rate is 3 to 10% at 10 years. If the tumor is not in an accessible location and you could only do a subtotal resection, you consider adjuvant radiation therapy based on the residual tumor location, and the local progression rate includes 40 to 50% at 5 years and approximately 60% at 10 years, which is a big difference between 3 to 10 if you do a complete resection. So this is the treatment for grade 2 and grade 3 meningiomas. They have a higher recurrence risk, even with complete resection, and adjuvant radiation therapy often recommended for local control. So with regards to grade 2, if you have an incomplete resection, the recurrence or progression rate is 60 to 100%. Adjuvant radiotherapy improves local control and may improve survival, and it aims to delay neurological decline. If you do a complete resection, the role of radiotherapy is debated in this case. So you try to balance the benefit versus the radiotherapy risks that the patient might have. Consider radiotherapy if the patient has low risk for complications. And the surveillance for these grade 2 tumors include MRI at 3, 6, and 12 months post-op, then every 6 to 12 months for 5 years, and afterward, every 1 to 3 years. The treatment for grade 3 meningiomas or the malignant tumors, so they are locally aggressive and fast-growing. Radiotherapy is the standard in initial treatment for these grade 3 tumors. Recurrence rate is 60 to 90% within 5 years, and the 5-year survival is approximately 20 to 50%. The post-treatment surveillance is MRI every 3 to 6 months for 3 to 5 years, then every 6 to 12 months. So just quickly on the radiation therapy, they could have traditional external beam radiation, example, the gamma knife. Oh no. Traditional external beam radiation therapy, which is a single beam of radiation, often 5 times per week for several weeks. They have radiation exposure to the adjacent tissues and may cause vision loss, memory loss, and stroke. And there's the stereotactic radiosurgery, which is the gamma knife. These are higher doses of radiation using multiple beams at a precise target during a single session outpatient procedure. Adjacent structures are not as prone to unintended damage from radiation. Symptom management. So medicines may be used when tumor removal is not feasible. You can treat the patient with anticonvulsants to help prevent seizures. You can treat the patient with steroid and anti-inflammatory medication to decrease the swelling in the brain. And they may introduce methods to reduce the intracranial pressure. For patients with increased intracranial pressure due to the blockage of CSF, you can place a shunt. This is just a summary of the treatment methods that we went through. So WHO grade 1, 2, and 3, gross total resection and subtotal resection, and the surveillance afterwards and treatment. And finally, the differential diagnosis for meningiomas, you can classify it between neoplastic and non-neoplastic. The examples for neoplastic include solitary fibrous tumor, lymphoma, plasmacytoma, metastatic carcinoma, melanocytic neoplasms, gliosarcoma, and leiomyosarcoma. Just quickly on the solitary fibrous tumor, which could look like a meningioma. So in this picture, you're seeing a solitary fibrous tumor in the right parietal region. In image A, you're seeing T1 without contrast and B with contrast, and C, you're seeing a sagittal T1 with contrast. Note features that may be mistaken for a meningioma. They have a broad base of attachment. They're iso-intense with brain on T1 and T2 non-contrast sequences, and they have a dense enhancement with contrast. So there's no way of really knowing if it's a fibrous tumor or a meningioma in this case. With regards to the non-neoplastic differential diagnosis, you have things like sarcoidosis, granulomatosis with polyangiitis, histocytic disorders, IgG4-related disease, Russell-Dorfman disease, and tuberculosis. And these are some clinical clues that you could introduce to try to differentiate. These are my references. Thank you for your time.